Thank you very much. Thanks very much for the kind introduction. And I hope you'll find interesting this session tonight, which is on one of the topics that is particularly close to my work. Starting from the beginning, pancreatic cancer is not the commonest cancer, but is a big killer, as you will see during the presentation. The incidence is about 10 people per 100,000 per year. The late tend to present quite late, when unfortunately there is not much you can do other than palliation. And certainly only 15% of patients newly diagnosed with pancreatic cancer are potential surgical candidate for an operation. The others have metastasis, so the tumor has already spread from the pancreas, or is too advanced locally, as it is in this case. You can see a big lump, unfortunately, encasing all the vessels around. And no doubt, despite having improved markedly over the last 20 years, it's still associated with a considerable morbidity. It's a big operation, removing a pancreas, especially from the head of the pancreas. So, starting, as we said from the beginning, is a big killer with a high incidence of, with a relatively modest number candidate for surgery of those who present with pancreatic cancer. And overall, even in those where surgery is feasible, the overall survival is not great. The only a minority are alive in the long term. And still, surgery remains the only potentially curative treatment for these patients. What are the risk factors? As you know, for some cancers, it's quite clear what you can do to prevent it. From skin cancer, you don't expose yourself to the sun. From lung cancer, you don't smoke. For other cancer, it's a bit less obvious. But smoking remains the main risk factor for pancreatic cancer. Diabetes, obesity, chronic inflammation of the pancreas, Crohn's disease, a disease which affects the small bowel, periodontal disease, interesting, gum disease, is been associated with pancreatic cancer, diet rich in processed meat, and history of gastric ulcers. These are the main risk factors. And certainly any patient who has, any person who has two relatives, two first-degree relatives, even one in fact, who had died of pancreatic cancer, is a potentially higher risk than those who don't. How does it present? So typically, the commonest one of the commonest way to present is with jaundice. Jaundice means becoming yellow. And the eyes and the skin gets yellow because bilirubin, which is a particular substance produced by the liver, doesn't get excreted into the intestine because of the blockage of the pancreatic cancer, as it is in this case, and it spills over into the bloodstream and get deposited into the skin, and the appearance of bile typically is yellow. But there are other symptoms. Weight loss is certainly one of them. Patients with unexplained weight loss should be checked out because it's not clear why, and some of them will have an underlying malignancy. Abdominal, so tummy or back pain, dyspepsia, so difficult digestion, steatorrhea, where you have stools which are very loose, with a lot of flatulence, a lot of gas, a lot of wind, and difficult to flush. I know it's maybe not a bit weird kind of talk, but it's exactly what happens when the pancreas doesn't work. And clearly diabetes. And this is two examples of two unfortunate patients. This lady, in fact, ultimately underwent surgery, and you can see that this is the border of the liver and the gallbladder, and she was jaundice. And this gentleman, unfortunately, you can see where the liver comes to, so is so enlarged because of extensive liver tumors, liver metastases, which have replaced essentially the entire liver. And this man clearly could not be offered any surgical intervention. So what do you do? How do you investigate in these patients? The first standard, the first easy, accessible investigation is an ultrasound scan of the abdomen. It's non-invasive, it doesn't cost much, it's accessible. Every hospital, some GP practice even have it. So you can do an ultrasound scan and see if there is anything wrong. But this is not very sensitive. That's the main limitation. CT, body scan, you put the patient through the tunnel, or even a more sophisticated, particularly to look at the duct, the bile duct, or the liver, is an MRI. And then in some circumstances, then you move on to what is a bit more invasive, ERCP. ERCP is a test, it's a camera test where you put a camera down and you cannulate the bile duct from the back. I'll show you a slide that shows a bit of anatomy and it will be more clear to you. And equally, endoscopic ultrasound scan has been extensively used over the last few years, over the last 10, 15 years. Essentially, it's an ultrasound scan probe, like the one used for a standard ultrasound scan, but is delivered through an endoscopy, so it comes very close to the tumor. You can also look at inside with the keyhole surgery and look at from close, and then some blood tests. In particular, this blood test tends to be higher in patients, about 70% of patients with pancreatic cancer. So there are a number of tests you can do. This is a pancreas protocol. This center in particular is a pancreatic center, pancreas and liver center, in fact. And one of the things which is clear is that the treatment of this condition doesn't rely entirely and solely on to a surgical expertise, but it's a really integrated system where you got a surgeon, you got oncologist, a radiologist, a gastroenterologist, everybody, anesthetist, intensivist, everybody has to do his bit to provide the best care. And this is an example. This is a very good quality of CT scan. You can see the liver here. This is the gallbladder, and this is where the tumor is in the pancreas, and you can see is blocking one of the vessels. This white vessel is, you see later, is called portal vein, which tend to be frequently involved by the tumor. And equally, if you want to know the relationship of the tumor to the vessel, you can do various things. This is a phenomenally beautiful reconstruction, 3D reconstruction of what the vessels are from a CT scan. So now you can look in different plane, from anterior, lateral, superior, and then you can reconstruct, and it's exactly the same as if it was in the human body. So it is quite phenomenal. And then that's what I meant by ERCP. So you go down, the patient has a camera test. This is an endoscope, which is delivered into the intestine and then deployed into the intestine. And then the bile duct, which is here, blocked by the tumor. You can see this is normal. This is normal, and you can see it is narrow because the tumor is squashing the bile duct. Then they put a stent and the jaundice disappears. And this is the classification, which probably means nothing to you, but you've heard many times probably hearing people saying what stage of your cancer was. What was the stage? Was it stage 3, stage 4? In summary, in essence, sorry, stage 4 is a very advanced with the metastasis, and stage 3 is when it's advanced. So that is as much as you probably need to know. Now, let's move a little bit further on something which is interesting. Pancreatic cancer is the only cancer, probably with lung, but even lung has improved marginally, which over the last 40 years, his prognosis has not changed at all. And you still have the same prognosis that you had in the 1970s. So only 5% or less of the total patients who present with pancreatic cancer, in fact it's about 3%, 3-4% are alive at 5 years. And these include the patients who have an operation. Those who do not have an operation do not survive certainly at 5 years. And what is incredible is that for all the other cancer, look at leukemia, breast. You might remember 20 years ago, breast cancer was one of the greatest killers. There were women, plenty of women died as a result of breast cancer. Testicular cancer, melanoma, colon cancer, bowel cancer now is defeated in a large number of patients. For pancreas, nothing has changed. And what is incredible is that despite all this, it is the one which received the lowest funding from the pharma industry. And over the last 2 or 3 years, one of the large charities in the UK, Pancreatic Cancer UK, has done a lot of work with us, or we've done a lot of work with them, in fact. And we have raised the interest in pancreatic cancer with the government. And there has been what they call an all-party parliamentary inquiry group, which has done a lot of work to try and make it more sensitive and certainly induce some attention at political level. And something hopefully is happening. But it's quite shocking that despite being one of the greatest killers, it doesn't receive much in terms of pharma industry. And there are reasons perhaps behind it, although I may be a bit cynical. One of them is that the incidence is not that high compared to others. And the other one is that, unfortunately, it does affect people who are a bit older. And so socially, they are probably less relevant than young or children. And as a result of it, there has not been a great interest, but hopefully things will change. Now, in order that you understand a bit more of what I'm talking about, this is the anatomy. So this is the liver, what your liver is like. This is a bile duct, this is a gallbladder, and the bile duct traverses the pancreas. So for tumor which originate in this area, in the head of the pancreas, what happens is that it will block the bile duct, and patient will become jaundice. But the most important thing, why is the surgery of the pancreas so complex and difficult? It is because, as you can see from here, the pancreas is intimately adherent and very close to a number of major vascular structures. So this is the aorta, the largest artery we have in our body. And this is the this is the superior mesenteric vein, and this is a portal vein. So these are two vessels run behind the pancreas. And anytime you want to dissect and remove it, you need to be very gentle to prevent any catastrophic hemorrhage sometimes. And most importantly, sometimes you have to reconstruct these vessels. So the relationship between this organ and the actual vessels is what determines the complexity and the difficulty in treating this tumor. Now, I want to show you this because this, I think, is also interesting. As you heard, I am certainly involved in quite a lot of active research on pancreatic cancer. And this actually is not a piece of my work. It was a piece of work of one of my colleagues who we collaborate on a lot of projects together. And it's an epidemiological study. And the interesting thing is that, as you heard me say in the beginning, pancreatic cancer tends to present late when the symptoms manifest is sometimes is frequently too late. The reality is that this is not quite true. And this is exactly what this study shows. These are the database from 8 million of patients from GP practice. We can't be too upset with GPs if they don't diagnose a pancreatic cancer, because the chance of seeing one pancreatic cancer is probably 1 in 5 years. So how can they possibly, out of 2, 3, 4, 5,000 consultations in a year, think of it? It's very, very difficult. But what this shows is that patients with pancreatic cancer present with a variety of symptoms, most frequently underestimated, completely underestimated, like abdominal pain, some chest pain, jaundice, as we say, nausea, vomiting, back pain, shoulder pain, sometimes diabetes, changing bowel habit. And what they do go to the GP quite frequently for that. Now, what you see in patients with pancreatic cancer is that the number of visits to the GP practice tend to become more frequent and intensify towards the time when the diagnosis is made. 0 is the time where the diagnosis is made. Compared to, you can see how frequently these people attend a GP practice, compared to control, so patients with equal symptoms, but clearly who never been diagnosed with pancreatic cancer. And what this tells you is that the frequency of attendance repeatedly over and over to the GP, sometimes 5, 6, 7 times, should alert, if not the GP himself, the patient, who should probably seek advice in a different matter. So what can we do? One of the areas of research has been exactly this one. We have, in fact, developed a tool with a questionnaire which is integrated with some investigations, and the final thing which joins the two things together is a lot of active work on identifying a biomarker, a simple blood test which could tell you whether you do have the cancer or not. Now, easy to say, extremely difficult to accomplish. The many markers are quite sensitive, but not very specific. Others are very specific, but not very sensitive. And you need it to be both sensitive and specific. You need to be able to identify and not miss anyone, and those who identify needs to be positive, in fact. It can't be a false negative all the time. So we are working on this, and hopefully, in fact, there is a big project which is carried out with Pancreatic Cancer UK and our charity, Fiorina. Hopefully, at the end of this 3 years journey, we might be able to have identified this, which would be a phenomenal breakthrough. And the impact of this could be to save probably between 200 and 300 lives per year in the UK only, which, if you remember, that 8,000 new patients are diagnosed every year in the UK, I think is a considerable benefit. Now, this shows exactly what I told you earlier. These are patients who have been operated. These are not patients with cancer altogether. These are just those who have been operated on. And as you can see, at 5 years, only 15% of them are alive. What kind of surgery we do? I mean, it might be interesting for you also to know what surgery we perform. If the tumor involves the head of the pancreas, what you do, you perform a procedure called Whipple pancreatico-duodenectomy, which is complex because, as I explained to you, the proximity to the vessel. The pancreas is also quite deeply located. It lies on the two big vessels, the aorta and the vena cava, which are respectively the artery and the vein, the largest in the body, sometimes of a caliber of a 50p coin, so large vessel. And if you do this procedure, you need to take the bile duct with the gallbladder, part of the pancreas, part of the stomach, part of the intestine, and then you needed to reconfigure. So you join bits and pieces together, because what ultimately you need is to restore quality of life, ability to eat and drink. This patient have to go back, although it will take time, to a normal life. And then you join the pancreas to the intestine, to the bile duct, and then come down to the stomach. And obviously the pancreas can be joined to a loop of intestine here, or like that, or on the back of the stomach. You can plumb it into the back of the stomach. Conversely, if the tumor affected the distal part of the pancreas, the one near to the spleen, you remove that bit of the pancreas and the spleen together. And this procedure is certainly less traumatic and less complex than the previous one. In some exceptional circumstances, like where the tumor involves the head as well as the tail of the pancreas, you remove the whole pancreas. And that is exactly what we've done, in fact, one today. This is a fairly traumatic operation because the patient becomes diabetic as well, and clearly needs to receive insulin for the rest of his life. What happens to a patient to have an operation? Some of you might have had or come across a friend, a relative who had pancreatic cancer. What should they expect? After a long operation, we transfer our patient to intensive care, where they normally stay for 1 day, providing they recover well. The following morning, they get transferred back to the ward. They receive some medications and antibiotics, and then they go clearly epidural. Epidural is, I'm sure most of you will know, is a small catheter deployed into the back of your spine. Women in labor, pregnant women, do have it quite commonly. This is very similar. It's a bit higher and induce can provide a very good analgesia. So drips, urinary catheter, drains. So as you say, all these reflect the complexity of the operation. Then they can only drink a little bit for the first few days. Then you check some of the tests before resuming oral intake. You mobilize them. It's the days when patients stay in bed for days. I remember when I started training many years ago, patients with a hernia were staying in bed for 3 days. Now today this would be inconceivable. The risk of clots in your legs, chest infection, and whatever else would be disproportionate. Patient, even after major surgery, sometimes even after a transplant, they get out of bed on the first day. They start jogging on the spot, start walking and mobilizing, and if they are pain-free or the pain is well controlled, the recovery is phenomenally faster. So this is certainly the new century medicine, if you like, but is every center in the world adopts the same principles. Some of these patients, however, are not able to eat and drink, and they need some intravenous feeding. And as I said, it is complex surgery, so they will stay in hospital for approximately a couple of weeks. But the complete recovery can be as long as 3 months. And there is not quite an age limit. I've done one of these operations in a gentleman from Chelmsford, in fact, who, an ex-Navy person, very fit, cycling 15 minutes a day, and who is 90. He recovered well, he's gone back to his family, and is happy. So clearly it is an exception, and 90 be regarded by most as probably a contraindication, a bit too much and too old, but certainly people in their 70 and even early 80s, it would be perfectly acceptable for this type of surgery. This is what it's like. There's a dressing on top, a couple of drains. As you see, this is a bag of the tube, which is unfortunately in the stomach, has to stay for a few days. And this is 3 days after a big operation for pancreatic cancer. Complications can occur, unfortunately, can occur in any kind of surgery, in this probably more than in others, particularly if you remember, you join the pancreas, the bile duct, and the stomach, and any of these join, any of these anastomosis, as we call them, so where you join the two organs together, you stitch them together, could potentially fail. And if it fails, the one at particularly high risk is the pancreas. The pancreas produces enzymes, which is what helps digesting the food, and produces insulin. But when it leaks, all these enzymes leak around, rather than get into the intestine, they get leaked around into the abdominal cavity. And you can imagine the disaster they can cause. This is a fluid which normally digests the food, so process the food, having it floating around in the abdominal cavity can erode into vessels or other structures and cause massive disasters. And this is the patient, in fact, who had a big leakage with a big collection, and as you can see, this is a kind of melting tissue which is leaking out of the drain. Bleeding equally can occur. This is an angiography. You might be familiar with that. Some people might know about cardiac angiography for heart attack. The principle is the same. They put a catheter into the artery and then they block off the bleeding, as it was in this case. And the operation, how does it perform? Currently, certainly for the tumor in the head of the pancreas, very few people perform it laparoscopically. Most of us perform with what we call a rooftop incision or a transverse incision, occasionally through a midline incision. But you need space. You need space, you need to have a good view. And remember, this is a kind of surgery which cannot be repeated once or twice. You have one chance to have it done properly and well if you want to provide the best radical oncological treatment. So you need to have a good view. The surgeon has to be familiar and confident. This is not a case frequently for laparoscopy unless the tumor is particularly small. And this is obviously the other approach where you do laparoscopically, and yes, less traumatic, so small incision here in the pubis where the specimen is removed and a few little cut. And undoubtedly for the tail of the pancreas sometimes is doable, but the bottom line is far more important to have an oncologically radical treatment than going home a couple of days earlier. So the last bit of my talk should be on exactly what I told you earlier. Only 15% of these patients are operable. The majority of them present with the spread. This is a pancreatic cancer spread to the liver. As you can see, this is the normal liver, and this is a liver with metastasis. In these circumstances, there is no space for any surgery, and unfortunately, these patients tend to have a very short survival. Median is less than 6 months, despite the chemotherapy. But there is a group which is particularly interesting to me, and is the locally advanced, where the tumor is not spread distant, but locally and involve the vessel. And how do you decide whether that has gone too far? There is no, I'm sorry to say, a standard of care across the UK. We've got 26 pancreatic units in the United Kingdom, and not everybody does the same. Most importantly, not everybody regards operable what others do or do not. And this is a typical example. The tumor, for instance, who call borderline, where the tumor is adjacent to this vein or the artery, by some it's considered gone too far, by others, like us, I'm saying, and I'm pleased to say, consider operable. When the vein is involved in particular, and this actually is not quite a good slide, but there should be, anyway, you can see from here, the vein is running behind, and the tumor is indenting the vein. And if it does, we do currently, routinely, divide the vein in block with the tumor and join the two ends together. And by doing that, you can remove the pancreas with the cancer. And as I say, it is clearly more complex. Here we've done about probably 70 or 80 of these procedures. And the mortality, the risk of dying from surgery is in fact not dissimilar from the risk for a standard operation. So as long as you do it in a proper institute with the proper facilities and you are properly trained, it is certainly doable. So what do you do for this patient? Normally, you do receive some chemotherapy first, if they are advanced, and obviously if they progress while they have chemotherapy, there's not much you can do, and unfortunately this patient have to be considered purely palliative. But if they remain static or even shrink, then you can perform surgery with vascular reconstruction. And the benefit of giving some chemotherapy before, some of them are quite implicit. First of all, you can shrink the tumor. You don't depend on receiving the treatment on the condition of the patient, because the patient is quite well at the time, if has not been operated as yet. It might confer a survival benefit, and it might treat small cancer cells which are not visible. And this is exactly what I meant. So you can see this is a portal vein which has been clamped here and divided there, and then you replace. In fact, the case we've done today, you just finished, is a case exactly like this. We use a graft. We are lucky because we are a transplant center. So we use a graft from a cadaveric donor and replace the missing bit, which after you remove the cancer, you're left with the gap. So portal vein resection is what we call vascular venous resection, is a standard of care, and it should be performed in any pancreatic cancer or pancreas center in the world. This is not the case, but what it should be. When the tumor involves the arteries, on the other hand, that's far more controversial. And I'm pleased to say we do have a program here, which is called the arterial study, and it's an international study. Most importantly, it's an international database, so it's an online data set which we set up with funding from the Royal Free Charity. And what it does, it puts together the experience of surgeons from as far as Mumbai and Nagoya in Japan, to Stockholm, Heidelberg in Germany, Pisa and Brescia in Italy. So there are a number of centers which are participating, and hopefully in the next few years we will know whether this is a meaningful surgery or not. And clearly, there is no doubt, as I told you before, surgery per se can do a lot, but cannot cure, has to be integrated with other treatment. And in particular, the red dot line, shows what patients who have been operated on and received chemotherapy doing compared to those who do not receive chemotherapy. So the benefit is quite conspicuous, it's quite obvious, and has been proven in randomized controlled trial. All our patients who have surgery and are fit enough to have chemotherapy afterwards, they receive treatment. Chemoradiation or radiation treatment, on the other hand, is far less popular in the UK, more popular in the rest of Europe and certainly in the States, and then sometimes there is certainly a role for it. Unfortunately, as I said, the vast majority of the patients, no matter what you do, no matter how hard you try, they do not come to an operating table. They will not be treated by a surgeon, but they will be treated by an oncologist and sadly by a palliative care team. And it is equally important for this patient, though, to receive a very supportive care, which means chemotherapy or radiotherapy. Pain control is important. This cancer can be very painful. Nutrition, drain the bile, supportive care, as we say, and we shouldn't forget holistic needs and psychological support. Dying is obviously the worst thing which can happen to a human being, but the families of a patient who is dying are equally affected. And I want to close and conclude my talk just to say thanks for all the support that maybe some of you might have done or contributed, and certainly the support we've had from Fiorina, which is our charity for pancreatic cancer. It is a very sad story, but equally has turned into something beautiful. This was a lady, partly Italian in fact, then hence the name Fiorina, who had an operation for locally advanced cancer, which I had one of these patients who had a venous reconstruction. And unfortunately the tumor recurred very rapidly, and within 18 months, unfortunately, despite the chemotherapy and all the rest of the treatment, she died. And the family came to me a few months later and inspired us to set up a charity here at the Royal Free, within the Royal Free charity, but with his own autonomy, and is purely dedicated to raise funding on pancreatic cancer. And so far we have already supported some of the studies which I mentioned to you. Thank you very much for your attention.